To moderate our next panel, it's my pleasure to introduce someone who many of you know if you have worked or read studies about quality improvement over the years. You almost certainly know our moderator or recognize his name as an author. Dr. Eric Schneider is Executive Vice President for the Quality Measurement and Research Group at NCQA. That means that among many other key responsibilities, he is the top doctor, the person in charge of the team that is focused on investigating, illuminating, and elevating health equity. It's my pleasure to bring Dr. Schneider to the stage, and he'll tell you about the panel. Eric, come on up.
Great, thank you very much, Andy. Really is a pleasure to be here. I didn't know I had that much power. Thank you, Andy. I'm going to make better use of that in the future. It's really a pleasure to be here this morning. Actually, it's delightful to see so many of you here. And I'm especially excited about, after this morning's panel, to move to this panel around prevention and healthcare delivery and how to deliver it equitably, because delivering healthcare equitably is really central to the quality agenda and the health of communities and individuals. Health plans and systems, though, are the ones who have to actually take that, what we heard about this morning, and bring health equity programs to scale. And so today we have three superb panelists who have deep experience serving Medi-Cal, commercial, and exchange plan beneficiaries. And with us, they're going to outline their approach to the challenges of identifying and addressing disparities and engaging community partners to reach members where they are. So I'm going to start out, I'm going to let them introduce themselves and answer the first question, which is to tell us about their organizations, introduce themselves and their organizations, and then tell us about their organization's journey in health equity. And I asked them to name at least one thing they're most proud of along that journey. And I'm going to start with Ed to my left.
Great. Hi, everyone. My name is Ed Judd, and I serve as Chief Quality Officer at Inland Empire Health Plan, often referred to as IEHP. IEHP is a Medi-Cal managed care plan that serves about 1.5 million members in San Bernardino and Riverside County, and we have about 6,800 providers in our network. Just to put the size of our region into context, we're about 27,000 square miles, which makes us larger than about 10 states in the country. And I asked Eric before if I could make a plug. If any one of you in the audience is looking to move because space is tight, give us a look in the IE. We have a lot of room. But Eric, to your first question, I'd say that our journey towards health equity accreditation started about a year ago. And I'm happy to share that we received our NCQA Health Equity distinction 3 months ago, back in December of 2023. Yes. Thank you. So there's a lot to be proud of. But I think what we as an organization are even more proud of is that our attention and focus in this space happened way well before we decided to pursue accreditation. And in fact, the teams were already doing things such as stratifying all our measures by race and ethnicity, looking at the dashboards and creating QI programs to reduce some of the gaps we were seeing, whether it was identifying in the low desert a Black population that may not be as adherent to our controlling blood pressure medication measure. So there's a lot of activity and intentionality that went into improve that rate of performance for that population. And then the team felt that it wasn't enough to stop there. They felt that it was important to also audit our data models to ensure that the output of our models were void of any algorithmic bias or any, I guess, unethical outputs. So I just share that because it's really emblematic of us as an organization doing the right thing for our members, and how we go about doing it is just as important.
Jackie?
Yes. Hi, everyone. Great to be here this morning between you and lunch, but I hear you got refreshments, so we have your full attention. My name is Jackie Adjoa, and I'm Vice President for Health Transformation at Blue Shield of California. At Blue Shield, I'm responsible for our virtual care strategy, our Health Reimagined strategy, our clinical data strategy, as well as our health equity strategy. For those of you who don't know, Blue Shield is the third largest insurer, healthcare provider in the state of California. We insure just a little shy of 4.9 million members across all lines of business. We have a Blue Shield Promise plan, which provides health care for a little over 500,000 Medicaid members. I use Medicaid because I think we have folks from outside of the state. It's Medi-Cal here. And then we have our ACA population covered California, and we have a range of different coverage across different product types. Our purpose is to provide health care that is that is the kind of care you would want your friends and families and loved ones to have, that is also sustainably affordable. Some of the things we're most proud of, there's a long list. We did get the multicultural distinction a couple of years ago, and then we got Health Equity, NCQA Health Equity accreditation for our covered California line of business in 2022, I believe. We have a few things to be proud of, and some of them include some of the work we've done most recently. I like how Ed mentioned that looking at the data, as we were parsing through our data, we had this fundamental revelation that for some of the heavy hitters around health disparities, we were not going to be, there was nothing in our population that was going to make them significantly different than others. And a couple of those heavy hitters were maternal health, maternal child health inequities with our Black population and women of color. And so as we went through our data, we found that there were obviously disparities. Like I said, we were not expecting that we would be that much different from anyone else. While the range of differences might be different from one population to the other, we knew that we were going to have higher C-section rates, for example, for our Black moms, our Latino moms, and our mothers of color versus our white moms. And when we looked at that data, we saw that we were 4%, so 36% for our Blue Shield Black moms and 32% for our white moms. And we kicked off a pilot in 2022, 2021, because pregnancies take a little bit of time for you to have outcomes. Somebody said, can we just rush this along? We're like, we can't just make them have the babies. It is a 40-week gestation period. It's really 10 months. But we got really, really good results out of those. We saw a reduction in C-section for that small population. We saw an improvement in infant birth weight. We saw an improvement in maternal mental health as well. So much so that was so encouraging. We rolled that out to a bigger population. And I think we had funding to put 100 people in this to add doulas to help coordinate that care. That filled up so quickly, we had to add another 50, and that filled up so quickly, I think we only have maybe 8 slots left. I said last week we had maybe 15 left, and the results of those are already promising. It was encouraging as we talked this morning that the Assembly Bill, it was Assembly Bill 904, that got passed in October of last year, that mandates a doula included in all commercial benefits and Medicaid starting in January 2025. So we were already moving in that direction to embed it in our benefits, and then it became a law. So it's made it easier, because then you just get funding, right? Because now it's a mandate. So we were able to repurpose some of those dollars we wanted to use to find other ways to also help to reduce those disparities. So really, really proud about that.
That's great. Thank you, Jackie. And Catherine.
Hello, everyone. I'm Catherine Baresi. I'm the Chief Health Services Officer for Partnership Health Plan of California. And Partnership Health Plan of California is a nonprofit county-organized health system that services over 920,000 Medicaid members across Northern California in 24 counties. At least as of January 1st, we expanded into 10 new counties. What I'm most proud of is that I'm here representing a team of over 1,000 employees that are mission-driven folks. When Partnership opened our doors in 1994, we were invited in by the local Solano County Coalition, made up of providers, hospitalists, county-based organizations who said, we've got to do healthcare differently, and we've got to rally and align our resources to think about this differently. And that's the model with which we have operated every single day since then. So when it comes to health equity, I know earlier the panelists talked about listening and community engagement. I really come here with a sense of working with my teams and how we bring those voices to the front. And something I'm really incredibly proud of that we're doing at Partnership is around our tribal and birth equity outcomes. I think where the strength lies is where we don't look at things as silos in terms of interventions, where we look to align multiple things. So in particular, partnership, we have 18 northern rural tribal health centers that are participating in 2 cohorts, funded largely in part by partnership, to look at outcomes for birth and tribal members, in particular, layering in enhanced care management, a new Medicaid benefit, community health workers, doulas, and the Family Centered Birth Project, which is a clinically evidence-based program out of Johns Hopkins specifically for tribal communities, and nesting that as a cohort and a program for these health centers. And we can talk about what that engagement looked like, because this isn't something that you just visit and as a health plan say, I've got this new thing and I think you're the partner I need to work with. There's a real conversation that has to happen there for us to all get to that space together.
That's really wonderful. I'm reminded, I actually did my medical training in California in the Bay Area, and coming back reminds me of just the tremendous diversity of the state on every dimension. Reflecting, hearing it here today is really a special treat. NCQA's Health Equity Accreditation, Jackie, you mentioned that we had the multicultural distinction program, and Health Equity Accreditation was an add-on, an expansion, actually, a refinement of that, so rooted in that, I guess. And, but it's a relatively recent add-on to the NCQA accreditation programs. I wondered if each of you could reflect a bit more in the detail about what it was like to go through the Health Equity Accreditation program, and any reflections you have on that, what was challenging about it, and what benefits you're seeing as a result of being through it. And maybe we'll start with, well, actually, whoever would like to start. Maybe Jackie, I'll turn to you.
Sure. So it's a journey. So a lot of, as the NCQA programs grow, one of the things you have to be aware of is you have to have the capacity. And so one of the challenges we had was really making sure that we had the capacity to look at the various parts of the organization that needed to make the necessarily changes, whether process or documentation, to make sure that we were going to be able to be compliant with the accreditation requirements. It was really transitioning from the Multicultural Distinction Award towards NCQA. It was helpful for us as we did, and everybody's experience is different, which is why we have different folks on the panel here. And I know just from dinner I had with somebody yesterday night, she wanted to understand, is it better for you to do this one line of business at a time, or is it better to do all of it at the same time? And our approach was we went for Covered California first, and then we learned from that, and now we're working towards getting accreditation for the 3 other lines of business we have all at the same time. So it's really thinking, what is the best approach for me? How do I make sure I have the right resources, and I get my organization to start to think in the lens of what's now required?
Catherine?
Sure, and I'll jump in next. We are not, we don't have our NCQA Health Equity Accreditation yet, but we are working on it every single day. Even as I sit here in front of you, there's huge amounts of teams that are rallying around this, and the intentionality about this not being something that you do off the side of your desk, I think is huge. The partnership, we've had equity and quality interwoven within our operations at all levels for some time. I think the rigor of NCQA to formalize that process is what pushes the excellence, and it's going to cause your organization to think through things differently with a different lens, and that's the purpose. So at partnership, in terms of how it's outlined, we have it interwoven throughout the organization, everything from grievance to our HR department, to our provider services, and to health services. It's every single facet for all of those collection and data points. So something to think about in terms of how you structure it within your teams and your organization, for sure.
Ed?
Yeah, maybe just building upon what my colleagues up here said. The stakes are real and the stakes are high when it comes to this type of work. And for us and for myself, I'd say that it felt pretty much the first time I decided to cook for my wife. There was periods of excitement at the very beginning. You're feeling, let's do this, we've got this. Followed by periods of anxiety, which is like, am I even ready for this? Are we even ready for this? Should we even do this? and then followed by a period of relief, which is, phew, I'm glad we got through this. Just in case any of you are wondering, no one got food poisoning, so I think we were safe. But those feelings are real, and I just share that with all of you because, again, as I mentioned earlier, the work of this equity accreditation program is very important. And again, it's hard to separate what's at stake. And so what that looked like from a feeling perspective to an actual enterprise perspective, I'd say was pretty straightforward. So it started with commitment for us, commitment at all levels of the organization, from our management teams to our executive teams to our board of directors. And it wasn't a commitment that we're all in just to get a distinction for a little feather in the cap. It was really changing the culture of how we viewed and approached this work. And at the same time, that's when we hired our Chief Health Equity Officer, Lorena Chandler, as well. So there was a lot of intention, excitement at this point in time. And then the survey happened. And for us, the survey revealed three things. It revealed what we were good at, what we weren't good at, and a new way of working. So some of the things it showed that we were good at, it showed that we had some organizational strength when it came to data and analytics, and that we as an organization, IHP, did a really good job of pulling together a lot of different teams quickly to organize around this work. Just to name a few, I think in the first week we pulled our quality improvement teams, our population health management teams, our credentialing teams, our provider networks team, member experience team, teams, just to name a few. So we're really good at getting that buy-in across all the departments that we were going on this journey. And then what it revealed was what we weren't so good at. And what we weren't so good at is our formal documentation process, because we had a lot of work taking place already in the organization on this space. Ton of work on health equity, ton of work on disparity reduction, not such a great job at formally documenting everything that needed to be documented in a way that standardized the way we looked at our goals, our objectives, and our plans of action. So by having a better formal documentation process, what it then led to was a formal health equity plan and a formal centralized health equity program that then allowed us to tighten and coordinate all the work taking place within our organization, allowed us to set unified goals, and helped us really leverage program components so that we could meet those objectives. And I just end that it also showed a new way of working. So for us at IHP, our HR team is a team that historically may not have been as accountable to things related to NCQA accreditation. But for the health equity accreditation, they were able to step up and lean in really, I would say, awesome ways, where they were able to help develop policies and procedures when it came to hiring and recruiting and staffing, and also leveraging our HR DEI teams to help us as an organization figure out what it needs to look like as an enterprise that are fulfilling some of these equity requirements. So I just share that because overall, the experience I think was really good, and where we are today is a whole lot better than when we started.
That's really great, Ed. And there was a meal at the end too,
Yes.
maybe. So the health, there's been a debate that's gone on for many decades probably around quality and equity and what's embedded in which, or which leads and which is following. And I think what I'm hearing in the conversation here is that tackling the challenge of achieving health equity actually may have strengthened what your work related to healthcare quality more generally. And I just wonder, sometimes those can end up siloed or separated or run by different departments. Maybe elaborate a little more on how the work in health equity has actually influenced the way you think about managing the quality department and the equity. And whoever like to, Catherine?
I'll start again. So we do have a formal quality department. We also have a health equity team and a pop health team. And the way that we view their work is essentially symbiotic of one another. Those groups work so close together. I'm sure at some point they share a brain. And so it's not done in silos. What is outlined in our pop health strategy is vetted with our QI team and is cross-checked with our health equity. And the feedback systems that they've created within and without throughout the organization and the communities is huge. Because make no mistake about it, you could have a quality component such as closing a care gap around HEDIS that could negatively impact disparities in a community. And if you're not paying attention to it, you will completely miss the boat. And so it's really important and integral to the work that those teams are meeting very frequently and aligning around initiatives to bolster.
Yeah, I'm just going to add to that, because that just got a little flashback there. So in my organization, we have a clinical quality team. Somewhere adjacent to that clinical quality team is a team that helps stand up NCQA accreditation across the enterprise. And then we have a health equity team that's separate. And we found that we needed to work very closely together. At first, I set up quarterly meetings. We brainstormed and we said, okay, we need to close gaps. I'll give a couple of examples. Diabetes, hypertension, colorectal cancer screening. Those are just 3 examples. And we met with when I say we, the health equity team met with the clinical quality team to talk about existing care gaps. And as we were figuring out who would close what, we looked to the clinical quality team to help us understand where we had the biggest gaps. But they're not necessarily slicing it by race and ethnicity. And so in addition to, for example, getting colorectal cancer screening, we also said that we need to close disparity gaps for marginalized communities or underserved communities. So not only do you want to make sure we get screening, close the gaps, which is clinical quality teams thinking about, but we also need to be able to measure by however we're slicing our health equity or health disparities and make sure that we're driving to close those gaps. And so that relationship is close. So we started with an initial kickoff meeting, and then I said, we really need to have quarterly meetings, and now we're meeting every week.
That's impressive.
Well, I think for us, we view quality and health equity as parts of the same whole, because you really can't have one without the other. And it's important recognizing you're talking about 2 big pieces of work that you just can't bear hug, in one sitting, probably even in one conversation, let alone a year. So I think for us, what we intentionally tried to do was fold in all the bodies of work taking place within quality and health equity under a single governing committee. And so for us, that governing committee is our Quality Management Health Equity Transformation Committee, where we meet, we discuss, and ensure there's a holistic view to all the different things that are taking place so that we can leverage opportunities when they exist. We can avoid duplication of efforts, but we can also see how the different teams can lean in to advance some of the goals that we've set. But in terms of how the work gets done on a day-to-day basis, operationally, we actually have quality and health equity as 2 separate departments. And part of that was done by intention because we felt that the area of health equity needed its own department so they could do all things related to health equity, disparity reduction across the enterprise and even outside the enterprise. So we want to make sure that that was, in some ways, a standalone area. And we also wanted the department to ensure that they had department-level accountability because the work is so important. And as I mentioned earlier, the stakes are real and the stakes are high when we're dealing with people, specifically when it comes to reducing disparities. And so far, it's worked really well for us. Our quality teams and our health equity teams are working like hand in glove. And so far, it's been a really good partnership.
That's great. So, Catherine and Jackie, partnerships with community-based organizations are obviously vital to this work. I think in our earlier conversations, we talked a bit about that. And community-based organizations are quite variable in their infrastructure, funding, capabilities to deliver services. How have you been approaching that work, the need to engage community-based organizations and manage them, help them be successful?
I will say this is a really bright spot for partnership. We are invited into the communities that we serve. We are championed by the county boards of supervisors, and so it isn't, as my CEO likes to joke, a hostile takeover when we come over. And so engagement is key. As you heard Peggy talk about earlier, meeting people where they were at, and you heard CHCF mention about having stakeholder engagement. How we connect with CBOs, stripping away the titles and the power structures that are in place. I am not from a Medi-Cal managed care plan, right? I am Catherine. I am here to talk with you, and I want to learn from your community. You've heard the terminology, cultural competency used in healthcare. The term I like to use is community competency. What's working well? Tell me who's doing what, and let's reframe how we look at this together. I will say what's really unique about partnership is our geographic makeup. Sonoma County that we cover, Santa Rosa, which is one of the larger communities there, the distance from Santa Rosa, California to Crescent City, another area that we cover, is the same distance from Santa Rosa, California to Bakersfield. We're talking about huge areas within our network where there's no internet, where we have kids that get in their car to drive to a local Starbucks to apply to their local community college on their phone. So when we talk about health equity and leaving communities behind, we want to go, we want to see what's working well, and we want to have the conversation about how you have a seat at the table to make outcomes better.
Jackie?
Yeah, just add to that. When we were putting together guiding principles around health equity, we knew that it was going to be important that we have the perspective for the communities that we're working with. And so we came up with, first we needed to get rooted. We needed to understand what health equity was, what disparities of care were. We needed to actually get data that will help us understand the outcomes based on how we slice the data. We needed to integrate diverse perspectives, and that was really where the root of the community comes in. And obviously we want to close disparities, and we want to tell the stories about the outcomes that we have. And one of the things we learned, just to add to what Catherine said, was dealing with a health system like ours. We have security assessments, we have architectural assessments, we have firewalls upon firewalls, we have NDAs and BAAs, we have all this alphabet soup that small community-based organizations don't know how to deal with. I mean, they don't have the time. And we need you to submit encounters, and we need you to do things the way we do them. And we quickly realized that was not going to work. And so we had to, at first it was maybe 5-7 years ago, it was really about making exceptions to our procedures. And by the time you got to make the exception, you're 6-8 weeks in, if not more. But now there's more of a realization that these are CBOs. They work differently than us. The kind of paperwork we're trying to give them is really like a David Goliath type story where the large law firm buries you in paperwork for the next 10 years, and that way, it was really that. So really having that understanding of the approach has to be different than the traditional approaches we have with large provider groups and vendors. That was really key. So that's the only thing I think I want to add to that, because that was really good perspective.
That's great. Ed, anything to add there?
Yeah, maybe from the provider perspective, because I think we heard a lot of great information on the community perspective. We can't do this work as health plans without our providers. And some of the things that we learn at IHP is that in order to advance this work, the health plan has to step up in different and newer ways. So for example, what we found is that we need to support our providers to have the ability to step up into this space. But we also need to find ways to empower them so they could step up and step into this space on their own. So how that looked like for us, we supported our providers through financial incentives. So for us at IHP, we have a 2024 global pay for performance budget of about $288 million. So we want to ensure that the work taking place in our provider network is tightly related to quality and quality outcomes. And what we included in our 2024 program are actually health equity related measures. So for example, we ask our providers to complete a diversity and inclusion survey so we can understand what their comfort level is when it comes to DEI topics. We also financially incentivize our providers to collect data on our members on things related to social drivers of health, so we understand things such as food insecurity, so we know how to better serve our members. So that's kind of the space that we've been supporting our providers, I guess you could say through financial incentives and motivation, but we're also trying to empower them as well. And one of the things that we just started is by sharing with them scorecards and report cards on what their panel demographic looks like when it comes to race and ethnicity and language. And what was interesting is we just had a meeting with one of our IPA partners, and they looked at the information and they were pretty jazzed because they're like, wow, I didn't know that my panel size looked like this when it came to race, ethnicity, and language, and that then sparked conversations on things that they could do internally on their own to advance health equity. So all in all, I think our providers have been receptive to this. We still have a ways to go, but I think we're heading in the right direction.
That's great. I wondered if others wanted to reflect on the health data and working with providers challenges. Catherine, you look like you were going to go.
Gosh, there's a ton going on in this space, as I'm sure everybody in this room knows, in terms of access to real-time data and what that means. And I know that we've had conversations about a lot of data available with poor insights, right? We're talking about systems that don't talk to each other, things that are collected in a certain way that can mess with how the data is viewed or aggregated or collected. And I think California, we're at this early point of figuring out who's doing what, and on the back end, trying to push and pull this data. I think we're a far way away from analyzing and really being able to set out intervention and intention around it. One of the things I will share in terms of using non-traditional data sources, if you will, in NCQA health equity or just in your health equity journey of work, grievances. The Medi-Cal managed care plan, we have people who file complaints against care, right? And one of the things that we do, we look at that not as a complaint, that's an opportunity. That's somebody who's engaged in their health system, has picked up the phone and wants to call and tell somebody about it, about their experience and how to do it better. So aside from claims data or committees or working with communities, make no mistake about it, if you work with members, you are sitting on a wealth of data. And so I would really champion some of the non-traditional sources.
Yeah, to your point, we have a community review committee. It's still a bit of a tongue twister, CRC, where we get that input directly live from a group of folks who participate in the health plan. I'm also working on bringing in clinical data. As you bring in that data from a strategically selected sources, traditional and non-traditional, as you bring it in, you also have challenges because the data isn't exactly the same. So you have to normalize it, you got to deduplicate it, and all of those, and then you have to put that in a system that now ties in the last mile into people's day-to-day processes. So that you have to reimagine or re-engineer the processes where people do the work. Otherwise, you do now have the data. Let's say you get through all those processes, you have data on, I don't know, 95% race, ethnicity, SOGI data, with disability status, if you may, and then you can mine for, is this an area that's rural or not, or a healthcare desert, and then what do you do with it? So there's a lot of process steps, because as my team, some of my teams are bringing in more and more data, we realized just from loading data from the Epic payer platform, we have about 62% race, ethnicity, language data. That's great. Now, how do we plug that into our day-to-day processes so that folks who are doing the work not only get access to it, but how do we train the teams so that they know this is something that might tell me a different story? Insights, to Kathy's point.
That's great. I want to encourage people to come up to the microphones. We're going to open it up to audience questions, and I'm sure you're given the high quality of this panel, you'll want to, and their experiences, you'll have questions. So please step forward if you will. I'm curious to know about the member experience around the collection of the data as you were just describing it. Any insights there?
I will share candidly, within the healthcare operations at Partnership, it's collected in many different forms and by many different systems and many different people, which gets aggregated in terms of a warehouse that we have on the back end. But coming up, and this I think Ed kind of talks to some of the points that we were talking about, the source of truth, right? Where is that source of truth? When somebody calls into our member services department with an updated address or an updated pronoun versus something that comes in on a claim or on a HEDIS record, retrieval from our quality department. There's so much data out there, and yet where is that source of truth? And it's going to be important for NCQA health equity accreditation, but also it's more important in terms of you being able to real-time act and make strategic investments and decisions that will start to move the needle on these disparities. Because if you're going just on a whim off of a misplaced source of truth, you could actually cause more harm when it comes to health equity, and I think that's a cautionary tale for all of us.
Yeah, and just to add to that, just capturing the voice of our people that we serve, voice of the members at every touch point, every interaction, hearing their voices, understanding what their concerns are, getting to the root cause of why they're saying the things that they're saying is a tremendous benefit, and it'll only help us do our jobs better so that we can better serve our people.
Great, thank you. I see a couple folks at this microphone. Please identify yourself and ask a question.
Sure, absolutely. So Felix Nunez, I'm the Chief Medical Officer at Gold Coast Health Plan. We're a Medi-Cal managed care plan in Ventura County, California. And the question is this, it's actually a plea for some help. I have folks that think about health equity or have trouble decoupling it from quality, saying that, well, if our population is majority Latinx, then by increasing our quality scores, aren't we addressing health equity de facto? I always shoot back, well, the rising tide raises all ships, but if the ships weren't equal to begin with, right? But I'm trying to get some help in understanding how I can counter that perception that just addressing quality metrics and dealing with that is in and of itself impacting health equity. Thank you.
That's a great question. Anyone want to jump at it?
Sure, I'll go. As I was, it's a great question. As I was explaining earlier on, when we started to get a little bit more mature, and it's still in the early stages of our health equity journey, we established some guiding principles. Those guiding principles included getting rooted. And that's really to the point of that question. If the teams who are working on this don't understand what is health equity, what are healthcare disparities, what may have led to those historically. This is not just an individual health disparity issue. There's your micro issues where you're looking at individual people, and then there's the meso where you're looking at the community. What's going on in that community? And then also structurally, what systemic rules do we have in place that may have contributed to certain populations having the outcomes that they have that persist today? So there's an educational impact. There's an educational piece that needs to occur. And there are programs out there that already exist, already well developed. We brought one in. We tried to push for, this was in 2021, we tried to push for having that training across the entire enterprise of 7,500 employees. That's challenging, right? Because it's not something you just do in 30 minutes. This was, when we condensed it, it was a 3-hour program, and it was really one that you wanted to stage. You wanted to do it in a little bit and go back and reflect. It took me a while to go through that training myself, and it helps people understand some of the history and the things that are programmed in our systems that may actually lead to continue to propagate disparities. So there's an education component there. And it's the same thing for members, because I know we're talking about having data, race, ethnicity, language, SOGI data, but there's still a lot of people who don't want to give you that information because they don't know how you might use it. And so that's a big thing. I know if I get asked for my race and ethnicity or language is spoken when I'm filling out application forms, I have a second thought. Do I actually want to provide it? I don't know what you're going to do with it.
Just one thing I would also add to that, permission. Permission to not apply a minimum performance level across the board as a medium-sized t-shirt. I think when you get into health equity and you start looking at the data and you see where these huge gaps are and deltas in terms of who's actually reaching the standardized health outcomes, it is okay and hopefully appropriate for you to strategize around moving the needle around specific populations for a specific benchmark. Granted, we want everybody at a certain time and space, but as we've heard this morning, we've got layers of institutional racism to dig through. So you've got to think strategically about this population, this measure, and how we're going to pull them up first and what's meaningful at a rate for them versus entire groups of people. And I think sometimes, not to my quality people, it's the overarching goal. Got to get them to 50, right? And with health equity, you've got to look at it differently.
Yeah, just maybe to add a little bit more to what my colleagues had shared, I'd view quality in a similar fashion to population health management. You manage a population, but the population is made up of specific individuals. In the same way, when we think about what is quality doing, what is health equity doing, when they're both kind of tucked under a quality measure or metric or a benchmark, I think you're talking about an opportunity to leverage things that the quality department may historically be really good at. For example, the technical requirements, the informatic pieces, the things that are needed for regulatory reporting purposes. And when a gap is identified, having experts that know the space of health equity so well to be able to address different types of QI initiatives that are maybe non-clinical. They could be things related to air, housing, food insecurity, maybe even agency. So you're now talking about things that are structural, that are very tied to social drivers of health, but with a team and a group that are experts in that space that then help improve overall quality performance. So that's another way to maybe kind of look at it.
Yeah, I've found in my primary care practice that sometimes teams would complain that we were trying to create a one-size-fits-all sort of approach with our quality measurement, and then when we would say, well, actually, no, we need to treat everyone as an individual and give them the care they need given their experience, backgrounds, resources, you're sort of bringing them back to that insight that clinical care is not delivered one-size-fits-all to, and not everyone who's coming through the door is the same in terms of their background and experience. So there's actually a way of turning that question around and sort of saying, well, we're empowering you to recognize that we don't treat everyone the same way and that we actually have some biases in the way we treat, and that can be powerful as well, and support the quality agenda, as the panelists are saying. Next question. And I'm gonna go, actually, why don't I go over to this mic, since I think I can't see that mic as well, but we'll go back and forth if that's okay.
Hi, my name is Reggie Tucker-Seeley. I have a two-part question. So my first question is about the prioritization of the disparity that you're focusing on. So given the centuries of systemic racism that are present across the many systems where you're likely to encounter disparities across a myriad of health outcomes. So can you talk about some of the facilitators and barriers to that or involved in that prioritization process? Then the second question is about how do we then communicate those differences across the various populations that we encounter? So how do you communicate those internally within your organization? How do you communicate those to providers and to the community? And we can't use the same language as we are communicating those differences. So if you can talk about those, that would be helpful. Thank you.
I think this gets back to what I mentioned as a bright spot for us with our work around tribal engagement. So in terms of how you strategize which priority, which disparity first, we had consultation sessions with our tribal partners, and there was literally no agenda other than just, we'd like to meet you. We'd like to know what's important to you, right? I think what's really important and beautiful in this space is the common ground, right? Out beyond that field of right and wrong, there's a field and I'll meet you there, right? This idea of, I want to learn from you, and I'm not coming in with my own agenda of what I think your healthcare should look like. I want you to tell me what's a priority for the mothers who give birth in your community. I want you as a tribal doula to tell me what you see as a challenge, whether it be the lack of housing, violence, behavioral health, and I want, how can I support you in those efforts? So I think there in terms of, the community will lead it, the community will tell you, right? And being open and listening to that. Bringing it back to the organization, that's a whole other band of politics, right, as we all know. So, but getting the providers and everybody within the system bought into that message, because really, if it's whole person, if it's patient-centered, the patient's telling you what they want. So it's just a matter of aligning our priorities that way.
That's great. We'll go to the next question.
My name is Ruth Harmon. I'm with Smart Rise Health, among many other things. We're working with some health plans in the Northeast on health equity accreditation. And my question really ended up aligning and piggybacking really well off of the first question. I think it was Catherine who mentioned earlier how focusing just on a quality program without understanding the impact on disparities could actually send you in the wrong path and make some of them worse. And I wanted to understand a little more of that from an example basis, or how any of you have seen where just focus on a quality program can be misaligned with, and how you have to watch out for that misalignment.
That's a really great question.
Since I brought it up, where I was honing in more particularly in Solano County, which is in the East Bay of Northern California, we have poor rates of well child visits for our Black and African American communities. And our quality team said, God, we've got to get these well child visits up. You know what we should do? We should do a call campaign. We should do all of this energy and effort to get these well child visits rates up. When our health equity officer went out and met with Black Infant Health and others to learn about why women and families of color were not showing up for their well child visits, it wasn't anything that that quality intervention could have addressed. And in fact, it probably would have alienated them further, right? Bombarding phone calls from an 800 number from a health plan, right? So that's what I mean about being careful about the intervention and just jetting out to meet a benchmark. It's more strategic to say, and what we do at Partnership, working with our population health management teams, our local county public health departments who have home visiting programs, our quality team, to say, why aren't they showing up? And what does that intervention now look like? Rather than just, again, applying this medium-sized t-shirt around a measure.
Thank you. Anybody else?
Yeah, I think it's just approaching it in a very holistic and intentional way. So for example, let's just say there are 5 to 6 subpopulations that everyone is looking to improve for a particular measure. And there's different ways to prioritize where to start, because it's really hard to start with all. But some of the things that we've learned internally at IHP is that when we're pulling on one lever, though that rate might improve, you may be actually unintentionally creating wider disparities with another population. They may not be getting as much attention and or focus. So while you're doing really good for a population, that gap could potentially be widening unexpectedly. So I think approaching anything related to health equity really needs to have an intentional, holistic approach where you're considering how pulling one lever might impact all the other levers as well. And it's not easy, but I will share that when we go about this work, it's really about hearing again from the community and the people. So, in any knowledge-based type organization or problem, the people that are closest to the work tend to know the answers. So while we might be seeing things that we think is the right way to start, going back to the people and the communities to verify, to validate, to confirm, and even, as Catherine had mentioned, to seek guidance, if you will, has helped for us. So I think it's not an easy thing, but something to keep in mind.
That's great.
Thank you very
we'll go
much.
to the other side here. Thank you. That was
Yeah, I think this has been touched on while I was standing here waiting to answer my question, but let me deepen it. And that is the nexus between disparities and inequities and social drivers of health, and how you conceptualize that and parse it out. So trying to understand the differences of sort of the impact of housing, for example, versus implicit bias and systemic racism. And also within the context of sort of the new information on social drivers of health that'll be gathered through the NCQA measure as well as hospital measures. Any sort of comments or thoughts about how that information might be used?
Yeah, Jackie, do you want to?
Yeah, that's a lot of different intersections we just mentioned there.
Sorry about that.
It's a lot, but it's good we're capturing that, because it's very easy to get overwhelmed and discouraged when you think about all the things that we need to either rewind or re-engineer. So when I meet with the health equity teams, or shared strategy committee meetings, or the board quality improvement committee, we say there's a lot to do here, and we want to create a virtuous cycle and a flywheel that encourages people to continue to do this work so we don't get overwhelmed. And so breaking it into little component parts, deciding which one you're going to work on. There are many. It's really difficult. You might say, you know what, you might tie it to a political agenda or policy. You might tie it to something that's already going on in that community and say, okay, this is going to actually propel me faster than if I was doing this on my own. And from all these problems, I'm going to pick this one because I think we can get traction because we have folks outside of this particular system who are willing to jump in with us. So I think if my encouragement to myself and the folks on my team is one step at a time. I actually, real quick joke, I love Rocky, the movie series, and I also watched Creed, and there was one thing that the coach said. He said, one step, one punch, one round at a time. You just got to take it step by step.
Ed?
In just a practical way for us and our teams, there's things you can control. And for us, there's things for us as a health plan we can control. There's things we can influence, and there's things we aspire to be. So I think when you think about all those pieces that you just shared, maybe just identifying what are the things that you and the teams can control and possibly influence. What do those phase gates look like? And I think starting there has at least helped us practically prioritize which levers to pull on first.
Yeah, I'm hearing, I also imagine that having willing partners in the field, whether they're provider groups or community-based organizations, really makes a huge difference in what to prioritize. Next question.
Hi, Sonia Duran Aguilar from Cahuilla Health in Central California, Tulare County, a medically underserved area. So I wanted to ask a very simple question, I think. When it comes to collecting race and ethnicity, what we've identified is that that might not be an easy question for our population to answer. To Jackie's point, our patients may not know what we're going to do with that data. We did launch a campaign titled "We Ask Because We Care." We translated it, posted it in our rural health clinics. But as we started to dig in and try to identify these disparities across breast cancer screening, colorectal cancer screenings, we've identified there's a disproportionate number of patients that are responding either unknown or decline to specify, despite us adding more detail, like, help us, where do you originate from? And so do you all have nuggets of wisdom you can share to make sure that we're not just checking a box and yes, we've collected it, it's a known. We can't pressure people to answer if they don't feel comfortable. But at the same time, we do want to make sure that we are able to address disparities in a meaningful way, but it starts with how we collect the data. So appreciate you sharing how to improve our processes. Thank you.
So one thing I will add in this space, not just as a nurse and a public health nurse, is the fear around data. We all have cell phones right now, and they're tracking your movements, they're tracking your calls, and everybody sees everything to everywhere at any one time. And when you're talking about communities that don't speak the language, that are not from the area, it's even a bigger hurdle and a bigger fear and a bigger anxiety. And so if you look at even Medi-Cal redeterminations and how that's going, right? People filling out, public charge. There's so much in this space to fear. This is where we can empower. And by that, what I mean is when you ask something of somebody, you have to show them what you did. You have to show them what you did with that. There is an abject disconnect between, can you help me out with this? And then, oh, that was helpful, bye, right? And so that collective community grassroots approach, I would encourage you, if you've got consumer advisory committees, community coalitions, to talk with them about what they fear their data is going to be used for and what they want their data to be used for. It's interesting to me, HIPAA is healthcare portability, because my A1C level and that data point belongs to me, yet it's shared everywhere throughout healthcare. And I'm cross-sectioned and I'm identified as a high or low risk person, and interventions are applied to me without my voice ever being told or planned in that. So yes, the data collection is important, but the person behind the data is even more important in terms of how we use it. And the catch is inviting them into that design process, inviting them into that communication process to elicit the trust.
That's great. Well, we are actually at our time. I apologize if there are other questions, but please come and ask them as we close here. Inviting them in, I love that phrase. Let's close on that phrase. And join me in thanking our panelists for a wonderful discussion.